Well, today we're taking a journey to the land of the long white cloud, to South Island, New Zealand, Nelson, in fact, to interview Dr. Robin Jones, consultant ophthalmic surgeon there. Now, Robin is an outstanding cataract surgeon, but also a very bold cataract surgeon as well. And I had the privilege of watching him cut his teeth in Hereford about a decade ago, tackling some very difficult cases with great results. Robin Jones, welcome.
Thank you, Simon. Those are very kind words.
Now, Robin, you trained initially in Wales. You then moved to New Zealand. You came back to the UK for a period of time, and then back to Nelson.
Sure. So yeah, I did my medical school in Cardiff and knew fairly late on in my medical school that I wanted to do ophthalmology. Made a presence in the eye department there in Cardiff, and I met a mutual friend, Jonathan Rossell. I believe he was one of your guests previously. And he, I think, was in his senior registrar year at that point. And I just stuck to him like glue, basically. He took me under his wing, showed me how to use a slit lamp, took me around clinics, took me to the operating theatre. And he also encouraged me to hang around when he was on call to see acute cases coming in. And that was, very useful knowing really how much effort and work was required at that stage to sort of break into ophthalmology, which I hadn't perhaps quite appreciated as a medical student. I knew it was a competitive career. So yeah, I stuck to him like glue. Um, and then one of my friends, who's now a anaesthetist, said, "Why don't we go to New Zealand and go surfing for a year?" And I thought, I've just done this year of neurology as a house officer, hoping to break into ophthalmology and have a good CV. I'm not sure going surfing in New Zealand for a year would be all that great on my CV. So I said, I'll do it if I can find a job in ophthalmology somewhere. So I wrote to the hospitals up and down New Zealand, and the only one really that wrote back with a ophthalmology related position was Dunedin. And I knew nothing about Dunedin, but took the job. I knew there was some good surf there. And it just so happened that that was the department headed at the time by Professor Maltino of the Maltino Drain fame. And there was some excellent surgeons there, a South African surgeon, David Peard, a local surgeon, Rod Keeler, and Professor Maltino were the sort of main backbone of the department at the time. And I spent a year there again, making a nuisance of myself, hanging around when I should have been on the ward clerking patients. I was usually down in the eye department. Um, and it was great. And towards the end of that, stop me if I'm going on too long, but I was thinking of coming back to the UK. I'd got a job offer in Wrexham, but by that time I'd met my then or to be wife rather, Emily, and it made it very hard to leave. And eventually I decided I was going to stay, and I did my ophthalmology training in New Zealand. And I finished that off with a year in Sydney as a senior registrar, which was great. That's probably the year more than anything that turned me into a consultant. And then as you know, spent a year with yourself refining my cataract surgery and some oculoplastic skills, which is a great string to the bow.
And are you in purely private practice now, Robin, or do you still see public patients?
At the moment, I'm about 50-50, which is a very busy week, really. There's not much slack in that. So um,
And
in
if
the future,
patients wanted to see you, how would they find you at the moment?
all our referrers locally, optometrists and GPs, know of our practice. I work at a joint private practice with my colleague Anthony Suter. We're Nelson Eye Surgeons. We have a website. We don't really go far out with our marketing just because at the moment we are pretty much well known for looking after our patients and doing a good job locally. So people seem to come and find us.
Turning to surgery now, how would you describe yourself as a surgeon to someone who's never seen you operate?
Probably it's quite boring watching me operate because I just aim to have things fairly routine and repetitive. So there's no bells and whistles. It's a relaxed atmosphere in theatre. We have some music on. There's not usually much talking. I talk to my patients because It's topical anesthesia and obviously talking to your patients is part of the anesthetic in some respects. But yeah, it's usually focused.
No, it's good. And turning to cataract itself now, Robin, which part of cataract surgery do you think relies most on judgment rather than pure surgical technique?
I think it's an old adage, but knowing when not to operate probably. So just because there's a cataract doesn't necessarily mean it's due at surgery, and it involves a good discussion with the patient, oftentimes relatives, as to when the time's right for operating. I suppose more recently, had a couple of patients with dementia who I thought would be fine sedated, but under the drape were just unable to remain still. And I think that's where you feel the pressure to sometimes to try and box on. You think, oh, it'll be fine, they'll settle down. And I think that's the road to ruin. And perhaps earlier in my career, I might have pushed a bit further, but more recently, I've been, I think, more disciplined in saying that we need to do this another day and perhaps with general anesthetic.
On the subject of operating on patients with dementia, and we touched on this with Paul Ursel the other day, but do you have any tips for more junior surgeons on how to get through a case with someone with dementia?
Um, I learned this from Tim Roberts, who's a high volume cataract surgeon in Sydney, and he said, if you sedate someone, then don't talk to them. And I think he's right because sedation in the context of dementia as well is a higher chance, I think, of disinhibition, which is really negating the whole idea of sedating someone. So I use head tape so that they're stabilized. I sedate them orally or with a nasal spray of midazolam. Rarely do we need IV sedation or general anesthetic. And really, once the operation is going, it's another instance perhaps where you want to be very efficient with your surgery, and I think time inside the eye equates to risk with these people. So you don't know if they're going to move or try and sit up or reach up. Having a nurse nearby to just watch out for a hand wandering up towards the face is also very useful. But yeah, trying to be in and out quickly, I think, is one of the things with operating on patients with dementia.
Do you ever have a relative in with you in that situation?
I do. Usually, the relatives I have in are translators. Sometimes the relatives themselves can be a bit of a distraction, but I'm not averse to that if it's thought that it might be beneficial to the mindset of the patient to get a safe result.
So, putting dementia to one side and just thinking of routine topical cataract surgery, are there any points in the procedure where you still slow down and really concentrate and focus, even now, having done thousands of cases?
I think it probably boils down to the rexis because you know usually that you've got a difficult case ahead of you if it's technically challenging when you assess it. But I think the rexis is crucial because for me that's my option of being able to implant a three-piece if it gets a bit spicy later on. So if you don't center your rexis and if you make it too big or too small, then being able to optic capture is not an option you have when sometimes that's your only place you can put a lens. So that's probably the bit I would concentrate most on. As you know, as a cataract surgeon, it's a lovely experience operating on autopilot, and your mind is far away. But because you're so used to what you're dealing with, you can do it on autopilot. But then all of a sudden, if something changes, even a very subtle change of the way an iris fluctuates with the fluid in a way that you're not quite used to seeing frequently, automatically you snap out into conscious thought. And I think one of the times I deliberately snap out into conscious thought is when I'm concentrating on the rexis in those cases.
So, how do you achieve a good standard Rexis? Do you use image guidance? Have you got Calodyne forceps? Use a Zepto? What do you do?
No, 10,000 hours.
Just use the force,
Experience,
Robin.
basically. Yeah, well, it's don't be distracted by a widely dilated pupil. That can pull you out too far. Um, yeah, I don't have any particular method I rely on other than experience now.
So as I understand it, you use a lot of premium lenses. What's your philosophy when it comes to refractive cataract surgery?
You probably summarize that in personalized, not standardized. So each patient's different. I probably don't use as many premium lenses as some of my colleagues. And that's just because it's trying to meet the patient's expectations, as you know, and the lenses themselves are often marketed as doing everything. And patients themselves will have relatives they know that don't need glasses after their cataract surgery. And so sometimes trying to achieve those results, um, you meet somewhat unrealistic expectations sometimes. So you have to sometimes spend more time, or more, the idea is to spend more chair time preoperatively to get things right for the right patients so that you don't have to spend a lot of time post-operatively trying to counsel those patients who perhaps don't have their expectations met by some of the lens technologies available.
We've sort of touched on this already, if you like, but what do you think patients often misunderstand about premium or presbyopia correcting lenses?
Yeah, probably some of the things I've just mentioned. It's the old adage of there's no such thing as a free lunch. So, in order to see everything with no downsides at all distances, you have to cheat the laws of physics. And we've yet to be able to do that and probably won't be able to. But that's not to say that the solutions available on the market now aren't excellent, but you've just got to choose your patients correctly and have realistic expectations. Those patients that I've implanted multifocals in, they've been delighted. But sometimes, as you know, you have a patient who thinks that's what they want, and when you get deeper into discussion with them on what their daily habits are, what their refractive needs are, you realize that they're exactly the opposite of the type of patient that should have those sorts of lenses. And for me, I think at the moment, yeah, I think it's something that is getting better, and there are more and more options available than ever before. But still, there's no perfect magic bullet just yet.
So choose your patients carefully. Obviously, choose your lenses carefully as well. Is there a lens or an approach that you've grown more cautious about over time or even stopped using?
Not really, only because I think on a general level, I try myself not to be on the first wave of any technology. It's great to be able to say, "Hey, I was the first to implant such and such, or first to use this device," and that sounds great. But I'd rather sit on the second wave and just watch what happens with that first wave before deciding. So when I explain this to some of my patients, I liken it to buying a newly released computer, say a new MacBook or something. Oftentimes it pays to wait until they do a mid-year refresh or a second generation of that model where they've ironed out a few of the problems they've encountered they didn't realize with the first um, round of computer.
So, Robin, putting your money where your mouth is, if you needed cataract surgery yourself tomorrow, what lens would you choose to have implanted in your own eyes and why?
Well, I think probably the first thing to say is I have no financial connection with any lens manufacturers. Um, for me, I'd choose something that has a long-term or a long history of reliability in both material and optics. So something well established, I think. And I'd probably go for a one-piece clear acrylic lens, of which there are many options available on the market. And at the moment, I'm in my mid 40s and I'm slowly getting a bit of presbyopia now. And I'm grumbling like my patients saying, they're making the print smaller on these things. And I'm holding these further away. And my children are saying, look at this, Dad. And I'm saying, oh. So I've been experimenting myself. And I think I would probably go for a emmetropia in my dominant eye and maybe a minus 1.25 in my non-dominant eye.
I'm afraid
I think
presbyopia gets
often,
worse with time, I've got to tell you.
no, I know, I know, but I think it's often easy to forget that blended vision like that is actually tried and tested, and you can actually simulate that for patients if their cataracts aren't too bad with a contact lens trial, And I think that's a very good way of knowing what you're going to deal with predictively with your outcomes and pleasing your patients.
And during your own phaco, which I hope doesn't happen for many decades, Robin, if the surgeon was talking you through it under topical, which part of it would you be most nervous about?
Probably the bit where the surgeon asks his scrub nurse to fetch his passport and book him an Uber. But probably all of it because we're first of all we're doctors and we have an insight into this operation and we know exactly that it can go wrong at any point and so we'd probably be fretting at the draping. Removal of the speculum at the end, we'd be panicking. So I think
Yes.
we make all patients. When I operate, I have a few idiosyncrasies. I like my nurses never to say whoops. If someone drops something on the floor on the other side of the operating theatre that clatters, I then make a point of saying to the patient, "Oh, don't worry, that was just a clipboard hitting the floor over there," rather than leaving it to the patient's imagination. I don't refer to the chopper as the chopper. I call it the second instrument. Just little things I think that, when you're the patient and you don't know what's going on, there are a lot of things that can play on your mind, I think, when you're anxious.
Now, in your public practice, you regularly train junior surgeons in cataract surgery. What do you personally most enjoy from your teaching?
I think probably it's the ability to pass on techniques and um, processes that have been beneficial to me and been handed to me from other surgeons, some of whom long since retired, and just passing those useful bits of information along, knowing that they'll be useful to someone perhaps throughout the entirety of their career. I think that's quite a nice thing to be able to do.
And when you're teaching, is there a particular concept that's tricky for trainee surgeons to grasp early on?
I'm not sure there's one particular thing. I talk to trainees about cataract surgery and I say that you can't just learn to do cataract surgery and leave it at that. I think you have to learn to do it and then try and excel at it. And the reason being is that it's an operation. I mean, not for everybody. You might go into medical retina or do something non-surgical, but as a trainee, you might end up as doing as I have and as you have doing a lot of cataract surgery. The last thing you want to do is to be confronted with a daily operation almost that scares the living daylights out of you um, because you haven't really trained yourself to deal with complex cataracts or complications. So I try and teach the trainees that it's not, it's an active process that you have to keep refining and getting better and better at. Otherwise, you'll wake up every morning and be fearful of going to work.
And do you think teaching's changed the way that you operate yourself?
I think in some ways, yes. I've always been quite analytical of my own surgery because I've always sought to refine it. But I think when you're teaching someone else, there's a real onus on you to be able to justify your everything you do, every technique you have, every move you make. You should expect to be able to answer why you do that. So it does make you analyze what you do a bit more and have a reason for doing things, which I think is very important in surgery.
It's a very solid answer. So, Robin, you've worked in multiple different environments, New Zealand, the UK, lots of different countries and hospitals, and with a wide range of colleagues. And you probably had some conflict along the way. What have you learned about navigating challenging professional relationships?
Being honest and doing the right thing is paramount. And I've seen a few instances, especially in the private sector, where conflicts of interest have soured professional relationships, and that's unfortunate. But I think honesty and integrity have got to prevail. And it's important, I think, as doctors, especially, we're high achievers and we think we're good at most things we can turn our hands to. But actually, there's few of us that are naturally good in business. And so it's quite easy, I think, for some people to make business decisions that in the wider world of business could be ill-advised.
Turning to business now, I understand that you're in the process of opening your own clinic. What motivated you to take that step now?
A number of factors, really. I was thinking about this the other day, and it's a bit like I think of our house, and we moved, my wife and I moved in here, and instantly we're busy with children. Both of us are consultants, both of us on call responsibilities, both of us at that time were in private. And we came in and there were already some picture hooks on the wall, no pictures, but we just hung our pictures, just stuck them where there were hooks. And they haven't moved since. But we've become accustomed to them. You become, I think, blind to your environment when your attention is on the day job. So we've been on our current premises for about 10 years, and we've perhaps not realized that it's a bit rough around the edges. Um, it needs a spruce up, and we've actually canvassed our patients, and it turned out we didn't realize, but many of our patients struggle to find parking at our current premises because it's quite a large healthcare facility with physiotherapists, etc. Um, so that was a major thing that prompted us. And then also our landlords, I think, were looking to establish a longer term lease. So with us really needing to do something quite significant with a fit out, it just made sense. It's quite a good catalyst to do that now.
Good luck.
Thank
Now,
you.
if you weren't an ophthalmologist, what would you realistically be doing? And keep it clean, Robin, please.
Well, I mean, I'm not sure what options are really open to you in prison, but probably librarian. I think I've been open with languages. I was very interested in French at school, and I've tried to keep that going. I've used that as a good excuse to visit some really interesting places. I went to Madagascar on my medical elective to watch them doing extracapular surgery there. Been to New Caledonia on this side of the planet, which is lovely. So yes, maybe something in languages, but I think I gravitate towards anything that requires a lot of training. I think I'm interested in the way people train for things. I'm not saying I'll be any good at those things, but I'm interested in sort of, I know you're in Hereford, you've got the SAS there. I'm always interested in the preparation that goes on behind the scenes for that level of commitment, but also musicians. I don't play an instrument, but I'm interested in the practice and the acquisition of skills through putting in the hours, basically.
And who do you think is doing truly excellent cataract surgery in New Zealand that more people should know about?
Well, your other guest, Ben the Hood, took my answer here. This is Keith Small, who I would be hopeful you could maybe get on your podcast. But he's quite a humble person, so I'm not sure he'd be that keen. But he's really the ophthalmologist here, and he's the person I sent my mother to. So you can't really give higher recommendation than that. But if I were to, I suppose the other thing is the biggest compliment I had came just after I'd finished my training, where I bumped into a consultant who was one of my consultants in Sydney, and she said, "Oh, I was just talking about you. I was just saying you're the only registrar I trust to do my own cataract." And I've held on to that compliment for over 10 years now, 15 years. And it's the nicest thing someone has said. But I'm not just telling you this to pat myself on the back. I'd hand that on to one of my own trainees who was with me a couple of years back, a guy called Paul Sear, who's now operating in um, Australia. And he was, I think, a second year or perhaps a third year, but he was someone who was just, I was teaching him the minutiae that I'd only picked up in consultant years, and he was running with it. And just, I'd like to see what he's doing now.
Fantastic. Robin Jones, thank you so much for spending the last half hour chatting about cataract, and good luck with your new venture.
Pleasure. Thank you very much, Simon. Pleasure.